Thank you, Peter. So just to briefly set the scene, if I may, and then I will hand over to the colleagues in the theme to talk a little bit more about the specifics of the work that we're doing. But just to remind us all that well over 500,000 people die every year in the United Kingdom, in those sorts of places that you see there. 46% in hospital and another 40% looked after by primary care teams at home or care home. And just to remind us all that most care in the final period of life is not given by specialists in palliative care or hospice, but by GPs, by geriatricians, by community nurses, by care home staff, and by the surgeons and physicians and others, rather than the specialists in palliative care who are always there and great help and support, but there is clearly room to improve care. We have an aging population with multiple conditions, and we need to remember that 2/3 of the week is now out of hours, nights and weekends. And the pandemic has clearly highlighted the importance of palliative and end-of-life care, particularly perhaps in care homes where there have been such difficult experiences in many care homes. So we have a great collaboration across the region with a number of colleagues in Cambridge, Professor Morag Farquhar and Dr. Perrier in the University of East Anglia, shared PhD studentships with 2 colleagues in the University of Hertfordshire, and indeed a national collaboration with the ARC in South London. And our aims are to address those 3 areas that you see on the slide there: the inequalities of provision, out of hours provision, and the needs of the aging population. And the presentations from 3 colleagues will highlight how we're addressing those areas. We found ourselves sucked into some important work during the pandemic. So in the Cambridgeshire and Peterborough area, producing guidance for general practitioners, community nurses, and indeed across the healthcare system. And these 3 documents that you see there were picked up nationally in a number of areas. We'll hear more about some of this research, but we have researched anticipatory prescribing in the community, bereavement care in the community. We've published 2 editorials in the British Medical Journal addressing the COVID issues, and then just very recently a major literature review concerning hospice inequalities. I won't dwell on this because Professor Farquhar is going to talk about the breathlessness work that she and colleagues are leading. And just to say that these are the opportunities that we have as a theme going forward. There is an emerging strategic clinical network across the east of England, which I've been invited to be the clinical lead for. And that is giving us opportunities as we emerge from the pandemic to build on some of the relationships we've developed in a large number of areas. So what I would like to do now, if I may, is to hand over to what I think is a recorded presentation from Professor Farquhar.
Thank you. So breathlessness is common in advanced cancer and non-cancer conditions such as COPD. It's almost as common as pain, but there are fewer interventions and resources for it and less public understanding of it. It's frightening and disabling for patients, and it's difficult to manage. It places considerable burden on patients' informal carers too, those family members and friends who support them by taking on multiple roles, including overnight vigilance. Like patients, their lives become restricted and isolated, but they're largely unsupported. They often lack knowledge, confidence, and strategies to help support the patient, leading to feelings of helplessness and powerlessness, which can cause anxiety, resulting in crises. Fear of breathlessness can drive demand for emergency health care, which is sometimes not warranted nor helpful. Research to improve carer support was prioritised by stakeholders at early ARC East of England palliative and end-of-life care themed stakeholder events. The Learning About Breathlessness research programme, known as LAB for short, comprises 2 studies to date, LAB 1 and LAB 2. LAB 1 was funded by Dimbleby Cancer Care and identified carer and clinician appetites for an educational intervention, 6 key topics that carers need to learn about, wide variation in how carers want to learn, and ways to meet those varying learning preferences. It proposed a web-based educational platform which could be accessed in multiple ways, with content mapped to carers' learning needs by covering those 6 key topics and to their preferences. Lab 2, funded by NIHR Research for Patient Benefit, then co-developed a prototype website with carers, patients and clinical experts. Feedback was sought from carers, carer-patient dyads and clinicians, and the refined website was then piloted with carers. Supporting Someone with Breathlessness then went live in May 2020 with over 300 delegates requesting access to 2 international online launch events. From the homepage, carers can access material related to each of those 6 topics Lab 1 identified as important to them, so that the website's content maps entirely to carers' self-identified learning needs. The website's design maps to carers' learning preferences, in that it's menu-driven, includes text, pictures and short film clips of clinical experts and peer carers, includes downloadable leaflets and links to other resources, and is badged and endorsed. The website can be accessed in 4 ways. It can be self-accessed or prescribed by a clinician. It can be viewed in peer or clinician-led support groups to generate discussion, or used in clinician one-to-ones with carers and patients. Additional funding from ARC East of England enabled us to add COVID-19 related guidance, which was essential given the launch timing, and a downloadable how-to-use guide for carers supporting someone with breathlessness due to conditions other than COPD or cancer. It also enabled us to edit the website's film clips for use on social media and design materials for clinicians to give to carers as suggested by our PPI group, including promotional cards and mock prescription pads. And if anyone would like any of these, please get in touch because we have some spare. Carers and clinicians have described it as doing something other websites and resources don't, by focusing on carers and going beyond symptom management. Importantly, clinicians have confidence in it, describing it as professional, safe and trustworthy. We'd like to thank our participants and website stars, recruitment facilitators, carer, clinical and methodological advisors, website builders, funders, and our funding host. Thank you.
Thank you, Morag. Yes, so I will be presenting our work in anticipatory prescribing. I've selected 2 studies to present here today. So just a little bit of background. So palliative and end-of-life care aims to alleviate suffering and to care for the person and their family throughout the disease trajectory. However, in the last days and hours of life, anticipatory prescribing has a huge role in administering controlled drugs if symptoms arise in those final days of life. So anticipatory prescribing refers to injectable medications that are prescribed just in case or if the patient needs them. So previous work from our research group has shown that evidence of best practice of anticipatory prescribing is scarce, although it is practiced across the UK. And despite NICE and regional guidelines, we know that there is variation in practice. So we wanted to understand what was happening during COVID. So we wanted to look at what the practice was across the region. So we conducted an online survey with the snowball sampling just to try to understand if there were any changes during the first wave of COVID. So we had 261 respondents between the 9th and 19th of April 2020, and they worked in various settings. You can see there was a nice spread across the region of respondents. And really, there were changes in practice, and there were changes occurring and innovations occurring through the first wave of the pandemic, mainly on routes of drug administration, drugs that were being prescribed, the total quantities prescribed, but also doses and ranges. People were considering that family members or social caregivers might be administering these drugs if there weren't enough clinical people to go in and administer these medications. And then, of course, clinical contact and patient assessment remote were really quite different because, of course, it was remote mainly. Then we wanted to know what was happening. So 6 months later, we conducted follow-up interviews. So we wanted to understand, out of those people who responded to our online survey, we invited 28 people, and we had 16 respondents to those follow-up interviews. So we conducted those on Zoom, we transcribed them, and we just have our preliminary results. So there were no notable changes in prescribing. There was still lots of preparation to change route of administration, but there were no notable differences there. Also, again, discussion considering family members with potential to administer the AP drugs, but still there was no need to do that. There was more use of phone and video, and there were pros and cons that were debated on using it. And the biggest worry really was supply. So there were not many differences of practice that were being considered in the near future, but supply was a worry. It was very interesting that we also got lots of positives coming out of COVID. For example, that video allowed presence in more meetings and to consult with non-critical patients. There was lots of mentioning around breaking down barriers between working groups within and between institutions. Of course, reusing those drugs in care homes, and rethinking reasons for existing processes and making changes to accommodate everyone involved. And then, of course, there was a really interesting discussion around decision-making, and there was a sense of empowerment and leadership in order to help what was needed to get the care that patients were needing at that moment. So there is a need for safe, standardized AP practice, but also there is a worry that we cannot compromise individualized patient care. Thank you.
Thank you, Barbara. That's a really helpful summary of that important study undertaken right in the middle of the pandemic. We're now moving on to a slightly innovative approach to palliative and end-of-life care, called a public health approach or compassionate communities. We involve harnessing community response. So over to Dr. Guy Perrier and his recorded video.
Good morning. This work builds on activities I've been leading on behalf of the Norfolk and Waveney Palliative and End-of-Life Care Group that is part of our local NHS Sustainability and Transformation Partnership, and soon to be an integrated care system. The ambition statements published by the National Council for Palliative Care in 2015 form the basis of our end-of-life care strategy in Norfolk, and these ambition statements have since been adopted by NHS England. The Compassionate Communities work relates to Ambition 6, which is entitled Each Community is Prepared to Help. The building blocks for achieving this ambition are to raise public awareness, to improve death literacy, and integrate and connect the efforts from existing community groups and volunteers, and enable new ways for neighbourhoods to provide non-clinical social support. It builds on a compelling observation from Professor Alan Kelleher that he has labelled the 95% rule, and that is, if you are a person who is identified as being in the period approaching the end of life and living at home, you may come into contact with clinical services up to about 5% of any day. This project is asking, what are we doing to support these people for the rest of the time? And the simple answer at the moment is, not very much. For the ARC, we have been working in the Great Yarmouth and Waveney population in focus, and I'm evaluating case studies in each of these areas marked in red. The project has combined 2 sets of funding from Norfolk and Waveney CCG and Ipswich and East Suffolk CCG, and the population in Waveney straddles the county border. These ideas are also integrated into the long-term plan, where the ambition in relation to end-of-life care is to involve people more and spread awareness of the importance of thinking ahead. A topical point that COVID has accentuated is the importance of generating an advanced care plan that describes our personal wishes and preferences, and holding these important conversations within our families and inner support networks. We have adopted a citizen-led community of practice method as a way of developing and translating the details contained in the Compassionate Communities Civic Charter to achieve the ambitions of augmenting capacity for support at a neighbourhood level in the communities local to the key anchor points that were marked in red on the map at the start. The community of practice work is being supported through an ARC cross-team collaboration with the implementation team, who I believe you'll be hearing from next. Thank you for listening.
Well, thank you very much, Stephen, Barbara, Guy, and Morag. They were really compelling presentations. So we've got a few minutes now for some questions and answers. I've got 2, one general one and then a specific one for Barbara. So the general one is about how your work and the changes that you've been supporting, how do you see it panning out in 5 years' time, when we hope that COVID will be something that we're living with only as a tiny part of our worlds?
Shall I start with that one? So I think, thank you, Peter, palliative and end-of-life care is not going to go away. It's been highlighted in the pandemic, but the needs are changing. Indeed, there is evidence of greater need as the population ages and the baby boomers come towards the end of their lives. And so the work, for example, that Morag has been doing around breathlessness and chronic non-malignant disease is going to be increasingly important, with an increasing focus on care homes as providers as end-of-life care. So the need is going to continue. And Morag, I don't know whether you want to comment, but some of the family carers supporting people will, of course, themselves be older and potentially unwell.
Absolutely. I think one of the things that the pandemic done is raise the profile of 2 really key issues in palliative and end-of-life care, which are managing the symptom of breathlessness and supporting informal carers. Those 2 things aren't going to go away as COVID abates. We're living with the situation with long COVID, and we don't know what the ultimate impacts of that will be. So they remain really high priority areas going forward.
Thanks. The next question, it's a huge question actually, so I'll ask it, Barbara, and if the clock ticks around to 10:50, then we'll roll it over to the panel. And I'm making that more likely by carrying on speaking. So the question was about the views of relatives with anticipatory prescribing, and whether I think you said that it didn't happen very often, but sometimes it might be the very last intervention in someone's life. So perhaps we will roll that over to the panel presentation, but someone wants to know a little bit more about what it was like for the relative. So I'll leave that one with you. So thank you all very much for such great presentations, really interesting.